Hello, fellow foodies, and welcome back. This is Dr. Cassandra Quave, and you're listening to Foodie Pharmacology, the science podcast for the food curious. Today on the show, we're going to dive into some very special recipes in a new program called Recipe for Health. My guests this week are Dr. Stephen Chen and Nat Irwin. Let me tell you a bit about them, and then we're going to dive into some really interesting questions. So, first, Stephen is the Chief Medical Officer of Alameda County's Recipe for Health. And this is actually a nationally recognized food as medicine program. It's embedded in the safety net community health centers, and it prescribes regenerative and or organic produce paired with health coaching to treat, prevent, and reverse chronic conditions and to address food or nutrition insecurity. By intentionally sourcing food as medicine from local, BIPOC, regenerative, and organic farms, this program generates a health multiplier effect. And it's called three cubed equity that generates benefits not only for human health, economic health, climate and soil health, and racial health equity. Um, Recipe for Health is actually one of California's first food as medicine programs used to successfully utilize the Medi-Cal, Medicaid, to cover food and health coaching services. Now, our other guest is actually Nat Irwin, and Nat manages the Health Cubed Equity work. His work focuses on evaluation of the human health, the economic health, and climate and soil health impact of the equity centered sourcing strategy. Nat's an experienced program and project manager in regenerative agriculture. He also has a background in qualitative studies with farmers. I'm so excited to have you both here on the show. We've covered this topic of food as medicine in a previous episode with Grady Healthcare System here in Atlanta, and this is kind of our safety net hospital in Atlanta. But it seems like you all are doing something a bit different in this very close tie with an intentional tie with regenerative and organic ag in your approach. So I'm really excited to learn more about it. So thanks for coming on the show. Why don't we begin, Dr. Chen, Stephen, if you can tell us a little bit more about what is Recipe for Health and kind of how is this approach structured in California?
Sure. So, as you shared in the intro, Recipe for Health is a food as medicine program that's in the safety net clinics. We call them federally qualified health centers. Um, and so it is essentially, if you are a patient, Dr. Cassandra, if you came in, you would be prescribed through our clinicians a recipe for health. And that recipe for health has two components. It's pretty simple. It's food and health coaching. And if we were to unpack that, it's food that's grown and intentionally sourced from regenerative and or organic farms that are local from BIPOC farmers when possible. And it's delivered to your home
Oh,
weekly,
wow.
weekly for 12 weeks as a prescription. That's the provision of food. Now, some of our patients, and perhaps you, if you're one of our patients, you say, it's great to get the food, but we also want to kind of embed that into our lives. And so that's where the health coaching piece comes in. The health coaching piece through our partners, and we can talk about who we're partnering with. They are health coaches, community-based health coaches, and they accompany you in a group setting at the clinics to amplify the effect of the food, to integrate that into your movement, because it's a whole health approach, movement, nutrition. You got that kale from last week? How are you going to cook it? How are you going to incorporate it into your diet? There's a mindfulness piece just to re-regulate the nervous system around the stressors that our patients feel. And then there's a social connection piece because it's a group effect. So patients with different diagnoses, blood pressure issues, fatty liver, uh, it could be diabetes, prediabetes, all depression, mental health can all come together in these groups, learn from each other, be coached, and have a health coach guiding them, supporting them during this prescription um, of Recipe for Health. So that's what the end user, that's what our patients get. Our providers, our medical clinicians love it because they have another tool in their toolbox to taking care of patients instead of only using drugs, pharmaceutical drugs, or instead of only referring them to specialists, they now can address a determinant of health as well as the social determinant of health, both the chronic conditions that a lot of our patients face, as well as food and nutrition insecurity. So let me pause with that as just kind of of what it would be like if you were to come to one of our clinics and get prescribed Recipe for Health.
Amazing. So, would you say, is this patient population, would they also, for example, be patients that might be under SNAP benefits or rely on food banks for a lot of their food
That's
before they
right.
come to you? Okay. Well, I
It's a
know one
It's
thing
an
with heart,
underserved
yeah,
setting. These safety net clinics, the federally qualified health centers,
yes.
um, take all comers. We are the safety net. When patients lose insurance because a job shifted
Mhm.
and they need to maintain healthcare, they can come to our clinics. If they are needing Medicaid, they can come to our clinics. And so we are really healthcare for all, if you will, and available.
Amazing. That's amazing. Well, I know one of the challenges in a lot of our food aid and distribution networks is that, a lot of the foods in food banks, including, what we have in Atlanta, is often highly processed, even ultra processed food ingredients. So for those that are um, not able to access adequate calories to support their families that go to these centers, they're not necessarily getting healthy foods. So this is a different approach, basically, from what you're saying. Is like you're actually providing whole foods, real food, with coaching.
That's right. I think a critical question that I really want to share with your audience and that I share whenever I speak about food as medicine is this question that is often not asked in food as medicine programs, which is where does the food come from? Food is not a drug in the same, or we don't want to think about it as only as a capsule, a pill. It has actually much more complex and richer history than a pill. When I prescribe pills, it doesn't matter where it comes from as long as it meets safety and efficacy and all of that. But when it comes to food, much more complex. It has history, it has power, it has culture, it has connection, it has family, all these things embedded. And so by asking the question, where does the food come from? And asking all food as medicine programs, all clinicians, we now as clinicians need to kind of think about where the food comes from. Who grows the food? How is it grown? What are the impacts in the way it's grown? How do we get this type of whole food to our patients? So it creates a whole cascade of important questions that are often overlooked by healthcare because we're so busy just taking care of that patient in 15 minutes. But again, if we as healthcare people are going to enter this space of food and using food in this way, we have to come in humbly and understand that there's a lot more to food than just the prescription of it kind of writ large.
Amazing. Well, and this brings me to my next question for Nat, because I know Nat, you're kind of seeing that interface of working also with the food growers, with these farmers that are engaging in regenerative and organic agriculture. Maybe we could start by, well, first, can you just refresh our listeners with a bit of information about what is regenerative ag versus organic ag, and then how that kind of plays into your program?
Yeah, absolutely. So regenerative ag is still a term that has not an ambiguous definition, but one that is being shaped sort of every day in this space, right? But generally, regenerative agriculture is a set of practices and principles that rely on minimal soil disturbance, keeping soil covered, ensuring that the way that land is managed is ultimately going to restore, regenerate the land, as opposed to degrade it. And so some way that folks will define regenerative is beyond sustainable. You're not just sustaining the current status of the land, you're actually trying to improve the quality and the health of the land over time. Within agriculture, land is very variable. It's hyper local. It's very regionally specific. And so, one of the thoughts around regenerative is that a single set of principles may not be, or a single set of practices rather, may not be the most effective on every single piece of land in any region. And so, it's sort of acknowledging a very outcomes based approach, one that can have sort of variability across different areas of land. Um, Organic has a set of practices and principles behind it and a USDA certification behind it as well, right? And so with organic, that is a set of practices that farmers can utilize and receive certifications around. And with those certifications, they can access specific, um, marketplaces and get premiums for organic. And organic is really at this point very focused on, yes, improving the quality of the land and having a big animal health component, but it's also really rooted in uh, not using synthetic chemicals, synthetic fertilizers, synthetic pesticides, and so it's often a set of maybe practices not to do, as well as a set of practices that you can be utilizing. And within Recipe for Health, all of the farms that we're sourcing from are certified organic, and many of them also utilize the term regenerative, or at least a set of what we would consider regenerative practices, even if they don't use that terminology. So it's still a term with variable definition.
Got you. So this is really focused on kind of the cultivation practices, the types of chemicals that your produce is exposed to during production. Are you also providing beyond vegetables and fruit? Are you also providing dairy or meat or eggs through this program, or it's all vegetable?
Right now, the focus is on vegetables. So we term this as a produce box. Other food as medicine programs may be doing more medically supported groceries, where it's a combination, like some of the food bank work that you've seen, where it's a compilation of different shelf stable goods and maybe some produce. And then there's also some programs that are focused on meals, prepared meals. Ours, we know that in our patient population, most of our patients have limited access to this quality type of vegetable and fruit. And so, and we know the health benefits of fruit and vegetable intake writ large. Just as a basic quote medicine, there's really nice benefits to the patients.
So, what would you say? Actually curious if you both have the same opinion. What would you say is the greatest barrier for your patient population to access this type of produce? Is it economic? Is it know-how and how to actually make food from these, raw ingredients? Or what have you noted in terms of like what are the barriers to eating better?
I think there's a number of barriers, and I'll start maybe, and Nat can add in as well. Um, Certainly the access to fresh fruit and vegetables in our communities. We're working in some of the most impoverished parts of Alameda County, where the food environment is one that is highly processed and ultra processed, right? Where you can get the cheapest quote calories at fast food restaurants, McDonald's or corner stores, where the stats show 60 to 80% of our food environment is ultra processed foods. So one is you have an inundation of that. And then the scarcity of like, well, where is the kind of other food, the whole foods? So part of it is access. What sometimes goes hand in hand with access is the finances, right? A lot of our patients, their finances go towards housing, and so there's sometimes not enough money for the food. And then this question of, well, what kind of food and how do you get that food? So that's a piece. I think there's also a cultural piece of the U.S. context, and I'll take my own heritage. I was born here. My family's from Taiwan. Um, Taiwan, everywhere you look, there's some type of food provisioning happening entrepreneurially or in some setting. And the food is often fresh. It's by the grandma that's been cooking and making this vegetable dish, selling at her stall that the high tech, workers come out at lunch and get. It's just available right there. And you have your chain stores and whatnot. So there's a food culture that is just where food is everywhere, and it's usually fresh food, high quality food. There's always plenty of ultra processed food everywhere now, but that kind of ability to have it so you don't have to be a chef in order to access food is available when the whole culture and the economy is structured that way. In our communities here, a lot of us are disconnected from food. We don't know where the food comes from, and then we don't even know necessarily how to cook it or to handle it, right? So part of it is those skills, but I don't think that we should necessarily make that the only burden for our patient, or that is the burden. You have to learn how to cook in order to eat. I do think there's compiling food. There's, being able to pay for food if it was available. So those are three kind of barriers that I would say. And then I think within the healthcare space, we as clinicians, we as physicians have not been trained on how to use something as fundamental as food to alter our patients' disease conditions or predilections towards disease. Using food as medicine in a 15-minute visit is challenging. I went to Stanford for medical school. I had zero training on nutrition or how to use food as medicine in a clinical setting. I went to UCSF family medicine residency, zero training. I got my training really from Andrew Weil's program in integrative medicine in a fellowship, where I began to kind of unearth this thing that has been invisible to us as clinicians, the power of this food. And so that's what we do. We train our clinicians on how to use food as medicine, and we make it easy for them to prescribe into our program. I'll turn it over to Nat, though, if you have anything else you want to add. I just gave 4 examples of barriers and,
Yeah, I mean, I think what I'll just add on to that, I'm in agreement with everything you just said, but thinking specifically about access to this very high quality produce, not just produce in general, but having regenerative and organic produce from local farms, like that's hard to access for a couple of reasons. One can be cost. This produce is often more expensive than conventionally grown produce. Um, Another is that we're often sourcing from these often smaller and local farms, and so they're not carrying that produce at every single corner store or Stop and Shop market or whatever the sort of large chain is, right? And so there's an access to this specific produce, and one of the reasons why I'm so excited about the food as medicine programs like Recipe4Health that are focusing on this intentional sourcing is because it creates an equitable access to produce that has become something with a very high premium, almost as like a luxury product. That's not the way we should be thinking about the healthiest food in our country, right? Um, I think the other piece that I'll just note on this is I think there's a lot of terminology right now that is confusing around our food. We see it on ultra processed packaging as well, but even on our fresh produce, there's not a real literacy in, well, what is regenerative? What is organic? What is this regenerative organic certification that's showing up on this, bell pepper? Like, and so I think with that, even if consumers want to go out and buy the highest quality produce, they might not know what they're buying or what they're selecting across a different set of practices and what the impact of that choice is, even if they can make those purchasing decisions.
No, those are such great points. I mean, I'll say, this isn't limited to certain socioeconomic classes either. I mean, speaking about education, I teach a lot of pre-medical students in my role as a professor at Emory, and also medical students, and we teach them, they have courses in advanced organic chemistry and microbiology and calculus and all of it. They come to my class and we talk about food and health. And I've had students that had no idea how to chop up a tomato, for example. So you can have, I think, people all across the economic spectrum, the education spectrum even, that have gone to some of the best private schools in the country that have no idea about where their food comes from or how to prepare food. Like, how do you make a meal from just a bag of produce? And so I find that a fascinating aspect of Western culture today, that we've become so separate from food, because I mean, this concept of food as medicine goes back, to many systems of the origins of medicine, not just with Hippocrates, but also in many systems of traditional medicine, of inclusion or exclusion of certain foods for your health. Um, so let's take this a step deeper. Tell me, let's imagine I'm one of the patients. Maybe I have high A1Cs. I'm like at risk for diabetes, and I get this bag of produce at my front door. what do I do with it if I have no I mean, I may not even know what those things are in that bag. Maybe it's, an eggplant or zucchini or things that I maybe just don't typically prepare. How do you coach patients through the transformation of a raw ingredient into a healthful meal?
Great question. And that's why we have the health coaches, and that the patients are really learning from each other. And so when a patient gets a recipe for health, when you, as let's just you as the index patient, you come in, my medical assistant screens you for food insecurity, check, that I get alerted. Okay, Cassandra has food insecurity. All right. I also know that Cassandra has diabetes or depression. Cassandra, you're on some medications. You want to try recipe for health? Yes. Okay, you do that. You get the produce at your desk or at your doorstep. You have the option to join the health coaching experience. And in that health coaching, just to paint the picture, imagine now you're coming to a clinic or you're doing it virtually, and you have 15 to 20 other Cassandras in the room with 4 to 5 different health coaches and a physician or a nurse practitioner there each week. And this is almost like your gym. We call it a behavioral pharmacy, right? It's one of our ingredients, and I can talk about the 5 ingredients later. But just to kind of center this piece, you come into this room like, I just got this kale. What do we do with it? You're going to meet Nat or Steven, and maybe Steven is Mexican American and you're, South Asian. And we're going to say, we both got this. Well, here's some recipes. What is spices that you use? So the idea is cultural learning happens because we have such a diverse patient population, and they're talking with each other, supporting and figuring this out together under the guidance of coach or getting the support from coaches as well as clinicians. The coaches are showing them, talking about the recipes, talking about the spices, talking about what worked. What is this eggplant? I've never had it. Or collard greens. What is this? It's in our box. Well, here's some tips. Here's what I try. Why don't you try this? That social connection is so powerful because people, I often think about my anthropology class in undergrad and that distinction between an expert in disease, maybe the doctor is, but versus an illness, the patient. When Cassandra comes and has an illness of diabetes, I might be able to be the expert on the disease and using drugs and providing a direction as a physician. But when Cassandra meets a Nat who also has an illness in diabetes and the details of that learning, not only on the medications, but now with food, that is where the secret sauce happens. And that's where the learning happens. So then people start learning. They either learn the skills or they also learn just the ways from each other. How do I adapt this into my diet? I'm getting different foods every week. This is totally new to me.
That's awesome. I love that point. It's not just a top-down system, but it's like within this cohort of learners and people engaging in the program. That's amazing. Now, you mentioned these ingredients of this recipe for health. Nat, can you share a little bit with us about what do you mean when you say ingredients in this recipe for health? And we're not talking about produce now.
I think Steven should probably talk through
Okay.
the 5 ingredients of Recipe for Health, and then when we turn to health cubed equity as
Okay,
it's
health
the
cube.
DNA,
Okay.
I'm happy to hold that.
Yeah.
Awesome.
So, when we think about recipe for health, the name recipe for health, any recipe has ingredients. And since we're a food as medicine recipe, we actually think of scale and almost in a regenerative context because we think other food as medicine programs can take these 5 ingredients and scale out and do something very similar. And so in order for you, Cassandra, as a patient to get the recipe for food and or health coaching, there needs to be infrastructure in place. And those 5 infrastructure or 5 components are the ingredients. The first one, which may be different than the place that you talked about in Georgia, which was a hospital basis, and we're using clinics. So our first ingredient is safety net health centers. All over the country, we have safety net health centers. So that's easy. Everywhere, every locale has something there. Again, we are embedding this work within healthcare. This is not food-based organizations trying to figure out how to plug into healthcare. It's healthcare proper, the belly of the beast. Healthcare is beginning this work. So we identify the health centers that want to do it. The second ingredient is what we call a food pharmacy, spelled Farmacy. Now, I remember when I first started this work, I thought, oh my gosh, we invented a term. And then I saw that Geisinger was using the same word and other people started using the same word, but the definition is different depending locales. How we think about this food pharmacy is similar to kind of a pharmacy that you would go to for pharmaceuticals. It's the system that's convenient, it's easy, that processes and prepares and gets and helps you fulfill your prescription for food. So to us, our food pharmacy is this component of a network of farms and the last mile delivery. So our partner is Farm Fresh to You. They're an incredible organization. They have a network of 95 plus farms. We select the farms that are closest to us, and they're all organic, right? They're all at minimum, and then they help provide the delivery to our patients' homes. So that's food pharmacy is their second ingredient. The third ingredient we kind of talked about earlier was what we call the behavioral pharmacy. Notice the word pharmacy. Again, Cassandra, if I prescribed you antibiotics, where would you take that prescription? You take it to a pharmacy, right? Well, if you didn't have a pharmacy, what would you do with that prescription that I'm trying to help you on your health on? It's hard to make your own antibiotics, right? You
Yeah.
probably wouldn't fill it. And isn't that in the life of a primary care physician? I'm a family doc. That's often what we do. We tell patients, "Go do this, do that. I'll see you in 4 months." We give them a prescription to do these things, and there's no pharmacy in place that support them unless they have access to Whole Foods or to a gym or they had the resources. Um, and so we said, let's structure the concept of food pharmacies, behavioral pharmacies with our health coaches to provide that support. The fourth ingredient is, how do you pay for this? Right? Is this through grants? We started with grants, but then we moved into Medicaid for people in the other states. In California, we call it Medi-Cal. And we're able to use, in the first time in US history, where Medicaid healthcare is actually paying for food. So when I write these prescriptions, it's like I would write a prescription for an antibiotic for you and it's covered by your insurance. This is now covered by Medicaid, but there's no copay, right? It's even better. And then the fifth ingredient, and this is happening at scale now. There's 13 to 14 states that have already approved Medicaid-based waivers to pay for food as medicine. 3 other states that are pending. We're one of those early adopter states. And then the fifth ingredient is you have all these ingredients, but you need someone to put it together. That fifth ingredient is my team at the county. We do all of the back end work, right? We train the clinicians. How to use food as medicine in a 15-minute visit. We train our clinicians on how to do that because we don't get it in our training. But I go to the clinics, I train them. And we connect the farmers so they can grow the food and we'll pay for the food. We do all that. They do the last mile delivery and that whole food pharmacy. We'll write the contracts to support them. The health coaches coach and we provide all the background, getting the referrals to them. And then by using Medicaid, it's highly regulated. It's tons of paperwork, all those prior authorizations. We manage all of that. So our clinicians really just need to click a few buttons in the electronic health record and we take care of it and we take care of the patient from there. So my team does the whole ecosystem of relationships. Those are the 5 ingredients that are replicable, done a little differently based on each context, but doable. And at the center of all of this is, and I'll turn it over to Nat when you want to ask about the HQD, the health cubed equity, because we are so focused on where the food comes from, the intentional sourcing of regenerative and organic, we believe that question leads to a health multiplier effect. And that health multiplier means not only do we get human health benefits, right, for you as my patient, but think about the farm worker who's preparing the food and the communities who are not being exposed to certain drift. That's a human health piece. And then there's the whole economic health, farmers, as well as patients, as well as the health system. And then there is also the ecological and soil health benefits. And again, I'll turn this to Nat to go deeper into these. All of these benefits because of this question, where does the food come from? And then the engine of healthcare demanding a type of food to shift the economy to grow food this way for our patients. That health multiplier effect with equity centered all the way through to make sure no one is left behind is the health equity model or the health cubed equity model that is the core of our Recipe for Health.
That's amazing. So I guess when we think about this model, this is tremendous that you're basically making it simple for physicians to really bring patients into this model. Um, when I think about broader adoption, obviously the top of mind are the economic outcomes from this. We know that healthcare is incredibly expensive. Pharmaceuticals are very expensive. Are you at the point in your program where you've been able to do kind of an economic assessment, um, when it comes to the best use of our investment for health? Do we see overall shifts in long-term health for patients, which would, of course, lead to, you know, much better, I guess, on the budget side, much better, outcomes economically for the reach that medication can have? Because as we know, like, chronic disease leads to not only, morbidity from that disease, but can then dovetail into many other conditions that then again drive and drive and drive healthcare costs. Um, are you looking at that, like how this model might prove more effective?
We are. That's part of our one of the H's, right? The economic health piece. And
Okay.
um, Nat, do you want to highlight anything in particular? I'm happy to come back after you because I know I've been doing a lot of talking. So give it over to you.
Yeah, yeah. Maybe this ties into that to the economic equity component because I'm just thinking about, especially with so much of healthcare under debate right now, right? Where we're there, the models are being reevaluated, and I'm curious, like, how can we show the importance of a healthy diet and long term impact, not just on patients but also on the healthcare economy?
Yeah. So, I mean, as we're looking at the economic health aspect of this work, there is certainly the impact on healthcare costs, right? And that's something where we have collaborators at a couple of universities who are really looking at what is the change in healthcare system utilization, ER visits, all of that. How can that be modeled to demonstrate the impact on overall healthcare costs? Or, how does reduction in medication use translate also to a change in healthcare costs? And Stephen can also talk a lot more on that. The other thing that we're thinking about with this, though, is what is sort of the local economic impact of this program, and specifically, again, the sourcing of regenerative and organic produce? So when we think about sort of the next sort of concentric circle out from our patient health, what is the broader sort of community impact of this type of program? How does it create a healthier economy? How does it improve the human health and the economic health of our farmers, our farm workers, the food hubs in our space, our patients who are consuming this food, and all of that has an impact on our healthcare system and healthcare utilization, and also the cost of this type of program. It does cost more to source regenerative and organic food, but in doing so, we're limiting all of these externalities that show up in other ways, right? Again, in our historically underserved farm worker and farmer populations that we have a focus on sourcing from. Um, yeah, maybe Stephen, I'll pass to you on some of the actual healthcare
Sure.
system piece. But yeah, thinking a lot about that sort of circle out from our patients in the
Yeah.
healthcare system as well.
I'm
Yeah.
thinking, like, even like semaglutide, prescriptions. I don't know if those are even covered within Medicare or not for diabetes treatments, but I know those are very expensive. So like, are there ways that you can use these, health interventions with food, with better day-to-day health practices to avoid such a heavy reliance on a lot of these prescription drugs?
Sure. And I'll just to speak to that piece, the semaglutides or the GLP-1s, right? The
Mhm.
actuarial cost is roughly, and the numbers change, but about $1,400 a month. $1,400 a month, right? For how long, right? Are people going to be on this for years? And there's side effects and all of that, right? So that's just a cost factor. So where I'm going right now with the example I'm going to give is this concept of cost effectiveness. Is this a good value for the money you're spending? So if I have $2,000, do I want to put 1,400 into GLP-1s? Or maybe there's some other interventions that can help. Um, Food is not going to cost that much, right, per month, even if it's organic or regenerative. Yes, it's more costly than conventional, but when you wrap in total program costs and everything, it's really not huge differential, right? It doesn't add more necessarily that much more, because the costs are not just in the food itself, it's in everything, right? It's the data transmission for Medicaid. It's the getting the food to the people's homes. It's all these other costs. So a cost-effective argument, and that's where there's a lot of research happening. The American Heart Association, funded with funding from themselves as well as Rockefeller Foundation, they're looking at what are the use cases we need to make to show cost effectiveness, clinical effectiveness, so that health plans feel comfortable paying for food, right, as medicine. There's other traditional metrics within healthcare. Does the emergency room visit or hospitalization rate go down? In our own study, we have partners at UCSF and Stanford and UCSF, and they've looked at a set of our data, and they've shown during COVID, while everyone was, their rates of hospitalizations and ER visits went up relative to those compared. So our patients who got Recipe4Health compared to controls, matched controls, it's a big deal, right? If we're going to get technical, we actually had a control group, had a 15% less likely of going to the ER, right? So that's a huge shift there potentially. I would then just say, as a third example on cost, the number one driver of death in our country from a risk factor perspective is an unhealthy diet. 500,000 people a year dying because they have some type of condition related to a diet. This surpasses smoking. This surpasses diabetes, obesity. It is a fundamental thing that we do every single day, once, twice, 3 times, 4 times a day. And that food going into our body expresses itself, through metabolic pathways, DNA, sequence, of genotype expression, phenotype, all of that stuff, that protein stuff that some of your scientist audience would like to get into. That inflammatory or anti-inflammatory pathway over time has an impact and leads to changes in our bodies that lead us down the chronic disease, chronic condition pathway. So I think there's that. And then the final piece in terms of economics, there's good studies that show that for we spend $1 trillion on food at face value a year, but if you took into the costs, those externalities, all those costs for the environment, to labor, to the human health aspects, it's really a $3 trillion price tag. So our quote, cheap food shows up at $1. It's actually costing us $3 trillion because of the impact on the diabetes, the more and more higher rates of diabetes, prediabetes, the impact on the environment because of the way we grow our food and treat our land, all of that stuff. So that's
Well,
what we really need to see.
it's also made artificially cheap because we federally subsidize so many of the ingredients that go into making ultra processed foods, which I still have a very difficult time understanding why we are still doing that, knowing that the data is there, that there are clear links between diet and, as you said, a whole plethora of different chronic diseases. And it's not just obesity and heart disease and diabetes, mental health. I mean, the list goes on and on. So I really applaud your efforts here. It's exciting to see how this program is really growing in California. How many patients have you enrolled so far? Do you have an idea on like scale, and where do you hope to go
Sure.
in the future?
Sure. I mean, and we started this out as a pilot, and then under this CalAIM experience, I would say in the last 4 years, from piloting till where we are now, over 7,500 patients enrolled. So it's 7,500 patients getting food weekly dropped off at their homes. Now, not all at once because it's over time. The highest amount per week we were delivering was around 1,200 families, 1,200 patients a week. Imagine that. Like, we're at scale. We're not one clinic. We started this at the clinic that I used to be the medical director at. And then
Yeah.
the story, we were able to grow, and we're not even at all the clinics. And so, we have a
That's a good
scale back.
question. You brought up family. I wanted to ask here. I mean, is there a multiplier effect where if someone in a family or in a household is preparing healthier foods, one would assume that would also affect other members of the family. They also might learn from this preparation, coaching that they're getting. Do you see that multiplier effect as well in your studies?
We know we haven't studied the household effect, but that is an area that needs to be studied, right? Because there's a ripple effect to your point. And I think there's probably gendered aspects to it that it could drive, depending on who prepares the food or in children and all of that. Um, we structure it so that any patient, because we're at the patient level. So, Cassandra, you come in, say you have a family, I would prescribe it for you and you would get this food for you. Now, you may say, well, I have a whole big family. How about everyone else? Well, if they come in to the clinic, they also can get the box. So you could have two boxes coming to your home because we're treating at the individual level, but recognizing that this food is going to be distributed. Most families always distribute the food. And so if they have three members of the family in a big family, they're going to get 3 boxes of food weekly.
Amazing. Wow. I know we talked about the health cubed equity. We covered economics. Nat, I do want to make sure we get to the other areas of equity. Can you tell us a bit more about that concept?
Sure. Yeah. So health cubed equity, health cubed, there are three sort of domains of health that we're looking at. We have human health, economic health, and ecological health. And we're trying to really kind of tie these together as that multiplier effect, all with this equity centering for why food as medicine programs should be sourcing in this intentional way. Local, regenerative, and or organic, and with a focus on BIPOC and historically underserved farmers. So when we think about, we talked about ecological or economic health a bit. We've talked about the human health piece. When we think about the ecological health piece, the reason why we're prioritizing regenerative and organic farms is because their practices are going to have a positive impact on the soil health, on the ecosystem level health of that area by not using, toxic chemicals in their farming practices that will impact the local water quality. We're also doing a lot of work that's sort of focused on bridging these different aspects of health. How can we create that through line from organic and regenerative practices as ecologically healthy, also as providing human health benefits? And so part of our work is focused on nutritional and food quality of the produce coming off of these farms. So within this Health Cubed Equity project, we're in the process of defining what we might test in produce that's being delivered to patients' doorsteps as sort of a bridge between, hey, look, this produce is really high quality because of the practices that are being done on these farms, the ecological health piece. And we expect that the quality of this produce will have a greater effect on the health of our patient, right? And so there's a
Yeah.
lot of research that still needs to be done in that space, but we're trying to zero in on how can we start to kind of articulate that argument and what can we measure as indicators or things that we can
Yeah.
evaluate to start to build that argument.
That's
Again,
amazing.
all with a focus on creating this sort of regenerative food as medicine movement.
It's great. I mean, I think I can see how well this ties into the periodic table of food initiative because one of their goals is to really understand all the different molecular components to different foods that people consume as that then translates into what, is happening on the human body side. There's another episode coming out this season, season 7 of Foodie Pharmacology. With Dr. Julia Menichetti from Harvard. And she's investigating something known as the dark matter of food, which is all these unknown molecules where you can take these very advanced, you know, metabolomics approaches and look at these signals and use tools like AI and network analysis to better understand, what are all these unknowns in foods? Because um, I think as consumers, we can often taste the difference. Forgive me, for the audience, I always tend to harp on tomatoes, but it's something I feel like everyone knows, when you have that vine-ripened tomato that you've grown in your yard that you then consume off the vine, there's just a world of difference between something that was grown in a kind of industrial ag setting across the world and shipped while green, harvested prematurely, and then forced into redness through gassing. I mean, the chemistry is just different. And so I think it's exciting to see, you know, this idea of food as medicine is not just a gimmick. I mean, the chemistry in these foods, when grown correctly, can actually have incredible health benefits. So I'm I'm excited about your program. I want to thank you for sharing it with us. We're about out of time. Before we go, any last things like where can I direct people to learn more about this program? Do you have a website? Do you also take, donations from the public to help support your program? Any of that info would be really helpful.
I would direct people to Recipe for Health. So it's our website. And there's an email there if people want to reach out, and we check that regularly. And my staff, myself, or one of my team members will get back and respond. We're always open to donations. I think philanthropy has an important role in this moment with the retraction on Medicaid, where dollars are going to be short from the federal level. I think all it's coming back to the local communities. And I think there are a lot of people who have access to funds that want to figure out how to contribute. And we're at, one of my colleagues once said, for systems change to happen, you have to have systems level funding. And so, though we are retracting from some system level funding from Medicaid and Medicare, there is a lot of system level funding in philanthropy networks. And so, for people who want to respond to the moment, if someone could get me in front of Mackenzie Scott and I could pitch and share, I mean, that would be incredible. We could scale so far because other counties have reached out to me, said, how do we do this? Can we expand? Other states have reached out. Even in Japan, I'll be going to Japan because they're very interested in kind of agro-medicine and how to connect organic and regenerative farming, what they call nature-based farming, to clinic. And so there's a great opportunity. So get in touch with us at Recipe for Health, and we will follow up. And if there is a set of philanthropists that want to support and scale, we're always open.
Amazing. Well, I think it's undeniable that planetary health and human health are intricately intertwined. And, if we're going to support human health, we have to think about the whole system. So I want to wish you guys the best of luck. This is really exciting what you're doing. I'm looking forward to keeping an eye on how things progress. This was great. Thanks so much for coming on the show.
Thanks so much for
Thank you.
the invitation.
All right. You've been listening to Foodie Pharmacology, the science podcast for the food curious. We are coming to you now in our seventh season. We're in season 7. It's incredible. Reaching out to hundreds of countries, which is super exciting. And to keep the show going, I will put out my little pitch. I could always go for another cup of coffee. That's how you can help us with this show. You can donate to the show at this link. You can see it on the YouTube site. But if you're listening in your car and you don't have the video version playing right now, you can also simply go to foodiepharmacology.com. We have a button there that'll take you to our give us a coffee donation site. So thanks so much for listening. Stay healthy out there, eat well, and we'll see you soon. This Foodie Pharmacology podcast is part of a special series co designed with the Periodic Table of Food Initiative, also known as the PTFI. The views and opinions in this podcast are those of the presenters and represent the synthesis of science. The PTFI is a program of RF Catalytic Capital managed by a collaborative team at the American Heart Association and the Alliance of Bioversity CIAT that seeks to advance our fundamental understanding of food composition by providing tools, data, and training to scientists across the globe so they can better characterize the quality of the world's edible biodiversity. The PTFI's ultimate goal is to advance data driven solutions in the food sector for the health of people and the planet. Funding for the PTFI is provided by the Rockefeller Foundation, the Foundation for Food and Agricultural Research, C. Rave Foundation, Fourfold Foundation, and Atria Health Collaborative.